Welcome back to the deep dive. Today we're getting into a condition that can be, well, quite tricky in the clinic. Multiple myeloma. It often presents with pretty vague symptoms initially. It's complex, definitely crucial to understand, and for anyone working with hematological malignancies, getting a clear picture is just non-negotiable. We've done our homework, looked at the latest insights.
That's right.
And our mission today is, as always, to sort of cut through the noise and give you those key takeaways.
Absolutely. And it's not just about, ticking off symptoms. It's about really grasping the whole process behind multiple myeloma, from how it starts at the cellular level right through to how it affects the whole body.
Yeah.
Understanding that is just so valuable for spotting those early clues, the subtle things that can really make a difference for patients.
Okay, so let's jump right in. If you had to boil it down, give us that concise core definition. What exactly is multiple myeloma? What's the essence of it?
Okay, so at its core, multiple myeloma is a malignant proliferation of plasma cells. Now, plasma cells, remember, they come from B cells. They're part of our immune system. Normally, they produce a whole range of different antibodies. That's polyclonal production.
Right, to fight off different infections.
Exactly. But in myeloma, the key difference is you get this monoclonal protein, sometimes called a paraprotein or M protein. It means all these cancerous plasma cells are clones, just churning out one specific type of antibody, or it's sometimes just a part of an antibody, like the light chains.
Oh, okay.
And while we know the common types, IgG is the most frequent, around 55%, then IgA, about 21%. Light chain only is about 22%. It's really understanding the implications. For instance, those XF light chains, they can show up as Benz-Jones protein in the urine, or we measure them as free light chains in the blood.
And that's important because...
Because those free light chains are directly toxic to the kidneys. They're a major reason patients develop renal impairment, sometimes quite early on, even before other classic myeloma symptoms pop up.
That's a really crucial point. That distinction, monoclonal versus polyclonal, and the toxicity of those light chains, that sets the stage nicely. So who are we typically seeing this in? What's the epidemiology look like?
Well, the incidence is around 4 new cases per 100,000 people each year. We see it a bit more in men than women, roughly a 2-to-1 ratio.
Okay.
And it's definitely a disease associated with aging. The median age when someone's diagnosed is usually between 60 and 70 years old.
60 to 70, okay.
Another really important point is that it's significantly more common in people of African Caribbean origin. That's a key demographic factor to keep in mind.
Got it. Now, you mentioned how it affects the body. Understanding myeloma really means understanding how it damages things, particularly the bones. What are these rogue plasma cells actually doing in the bone marrow? Can you walk us through that pathophysiology?
Yeah, this is where it gets really interesting pathologically speaking. So you might have a few malignant plasma cells floating around in the blood, but the vast majority set up shop in the bone marrow. That's their home base. And they're not just passively sitting there. They produce various substances, cytokines, that basically send signals to other cells in the bone marrow. Crucially, they stimulate osteoclasts.
Those are the bone-resorbing cells, right?
Exactly. The cells that normally break down old bone, but here they get overstimulated, so you get excessive, uncontrolled bone breakdown. And that's what causes those characteristic punched-out olytic lesions you see on x-rays or scans.
Hence the bone pain and fractures.
Precisely. Significant bone pain, a much higher risk of pathological fractures, fractures with minimal trauma, and all that bone breakdown releases calcium into the blood, leading to hypercalcemia, high calcium levels.
Which has its own set of problems.
Definitely. Confusion, constipation, kidney issues. And it doesn't stop at the bone itself. Because the marrow is getting crowded out by these malignant plasma cells, it suppresses normal blood cell production hematopoiesis.
Right.
So you often see anemia, sometimes quite severe, because red cell production drops. Or even pancytopenia, where red cells, white cells, and platelets are all low. So you can see how this directly ties into the symptoms people present with.
Wow. Yeah, it's like a hostile takeover of the bone marrow, disrupting everything.
Yeah.
So given all that, what are the classic signs, the red flags we should be watching out for? And maybe some of the less common things too.
Yeah, the clinical picture can be incredibly varied. It really reflects everything we just talked about, the bone destruction, the marrow failure, the effects of that M protein. So absolutely, significant bone pain is a big one, especially new or persistent back pain in someone over, say, 50 or 60. That should ring alarm bells.
Right.
Pathological fractures, of course. Hypercalcemia is common and can cause those non-specific symptoms like fatigue, confusion, thirst, nausea, Renal impairment is very frequent. We talked about the light chains, but hypercalcemia, infections, even NSAY use can contribute. And then the anemia, usually normocytic or macrocytic, causing fatigue and shortness of breath. Sometimes broader pansteupenia leading to infections or bleeding.
So quite a range already.
Yeah.
What about neurological issues or things related to the blood itself getting sort of thick?
Good point. Neurological symptoms are a major concern. You can get spinal cord compression if a vertebra collapses or if there's an extradural mass of plasma cells. That's an emergency weakness, sensory changes.
Yikes.
And then there's hyperviscosity syndrome. This happens when the M protein, especially certain types like IgM or high-level IgA or IgG3, makes the blood literally thicker.
Right.
This can cause symptoms like headache, blurred vision, confusion, maybe nosebleeds or bruising. On exam, you might see engorged retinal veins or even retinal bleeds. In severe cases, it can strain the heart or cause strokes.
And you mentioned amyloidosis earlier.
Yes, that's another potential complication. Amyloidosis is when fragments of the light chains deposit in various tissues. This can lead to things like nephrotic syndrome if it hits the kidneys, heart failure if it affects the heart, carpal tunnel syndrome, and sometimes you see that classic periorbital purpura bruising around the eyes, the so-called panda eyes.
Wow, panda eyes. That's memorable.
It is. And finally, a high ESR erythrocyte sedimentation rate is often seen, but it's very nonspecific. Lots of things cause a high ESR. Only a small fraction, maybe 5%, of people with a persistently high ESR over 100 actually have myeloma. So it's a clue, but not diagnostic on its own.
That's a really helpful rundown. So if a patient comes in with some of these symptoms, what might we actually find during a physical examination? What are the hands-on clues?
Well, on general inspection, you might notice pallor from the anemia. When you examine the musculoskeletal system, you might find specific points of bone tenderness, say over the ribs or spine. Occasionally, you might feel a lump or see a deformity if there's a significant fracture, or plasmacytoma, which is a localized collection of these plasma cells.
Okay.
Neurologically, you'd be looking for any focal weakness, numbness, or altered reflexes that could suggest cord compression. And assessing their mental state is key. Confusion could be hypercalcemia or hyperviscosity.
Right.
Eye exam, fundoscopy might show those engorged retinal veins or hemorrhages from hyperviscosity. Checking the skin for bruising or purpura is important. And looking for those specific signs of amyloidosis, the panda eyes, maybe signs of carpal tunnel if they complain of hand symptoms. And then, of course, checking for signs of complications like heart failure, ankle edema, raised JVP, or any sign suggestive of kidney problems.
So a thorough exam can definitely yield some important clues. Given this whole picture, how do we actually nail down the diagnosis? What are the definitive tests?
Right. Confirming the diagnosis usually requires meeting at least 2 out of 3 main criteria. It's about putting the pieces together.
Okay, what are the 3?
First, you need evidence of increased malignant plasma cells in the bone marrow. This is confirmed by doing a bone marrow aspirate and biopsy. We typically look for more than 10% plasma cells, and importantly, they often look abnormal or atypical.
Right, the marrow biopsy, number 1.
Second, you need to detect that monoclonal protein, the M protein or paraprotein, in the serum or urine. We do this using electrophoresis and immunofixation, along with serum-free light chain assays.
Okay, protein detection, number 2.
And third, evidence of myeloma-related end organ damage. Classically, this includes skeletal lytic lesions. Traditionally, we used a skeletal survey, basically x-rays of major bones. But now, increasingly, we use more sensitive imaging like low-dose whole-body CT scans or even whole-body MRI. These are much better at picking up bone lesions, sometimes even before they cause symptoms. Other criteria for end organ damage, often remembered by the acronym CAB, include calcium elevation, hypercalcemia, renal insufficiency, anemia, and bone lesions.
CRAB criteria, got it. So marrow, protein, and end organ damage like bone lesions. Are there other tests that are important, maybe for prognosis or fine-tuning things?
Absolutely. Once the diagnosis is made, other tests are crucial. Serum albumin and beta-2 microglobulin levels are key components of the staging system, which helps predict prognosis.
Okay.
Cytogenetic analysis of the myeloma cells, looking for specific genetic abnormalities like translocations or deletions using techniques like CESA-PI-H, is also vital. Certain genetic markers indicate a higher risk disease that might need more aggressive treatment.
Right, the genetics matter a lot.
They really do. And one more point here, something I often stress. Always check the levels of the normal immunoglobulins, the ones the patient isn't overproducing. In most myeloma cases, these other immunoglobulins are suppressed, a phenomenon called immunoparesis. If they're not suppressed, if they're normal, it should make you pause and perhaps reconsider the diagnosis, or at least think about other possibilities.
That's a great clinical pearl, the lack of suppression being unusual. So this brings us to differentiating myeloma from things that might look similar. What are the main conditions we need to distinguish it from? How do we tell them apart?
That's a critical step. Probably the most common condition to differentiate is monoclonal gammopathy of uncertain significance, or MGUS.
MGUS.
With MGUS, you find a monoclonal protein, just like in myeloma, but crucially, there's no end organ damage, no C-CRAB criteria are met. The M protein level is usually lower, and the bone marrow has less than 10% plasma cells.
So it's like myeloma light, almost, but not causing problems.
Kind of. The key is that it's of uncertain significance. Most people with MGUS never develop myeloma, but there is a small risk of progression, roughly 1% per year. So these patients need monitoring.
That 1% per year must be anxiety-provoking for patients just waiting.
It definitely can be. It's about regular checks, usually annually, looking for any signs of progression. We watch the M protein level, blood counts, calcium, renal function. An abnormal serum-free light chain ratio in someone with MGUS does indicate a slightly higher risk of progression, so we monitor those patients perhaps a bit more closely.
Okay, MGUS. What else?
Another important one is Waldenstrom macroglobulinemia. This is actually a type of low-grade lymphoma, specifically lymphoplasmacytic lymphoma. The key difference is it's almost always associated with an IgM paraprotein.
Ah, IgM specifically.
Yes. And patients often present more with symptoms related to the IgM itself, like hyperviscosity, nosebleeds, visual problems, confusion, or symptoms from marrow infiltration like anemia or enlarged lymph nodes or spleen. Bone lesions are rare in Waldenstrom's, unlike myeloma. The bone marrow looks different too, with lymphoid cells, and often there's a specific gene mutation called MYD88.
So different protein, different clinical picture, different marrow findings.
Exactly. And finally, you have solitary plasmacytomas. These are rare. It's a single isolated tumor made of monoclonal plasma cells. It can be in a bone, solitary bone plasmacytoma, or in soft tissue, extramedullary plasmacytoma, often in the head and neck area.
Just one spot.
Just one spot. The absolute key here is the absence of disseminated myeloma. So no other bone lesions on sensitive imaging, normal calcium, normal kidney function, no significant anemia, and minimal plasma cells in a distant bone marrow biopsy. They might have a low-level M protein, but the disease is localized.
That makes sense. Clear distinctions are crucial. Okay, so once we've definitively diagnosed multiple myeloma, what's the approach to management? What does treatment look like these days?
Managing myeloma has become quite complex, but also much more effective. The first step is always to assess the patient overall, their age, their fitness, other health problems, and critically determine if they are eligible for high-dose chemotherapy, followed by an autologous hematopoietic stem cell transplant, or HSCT.
Right, the transplant eligibility is a big fork in the road.
It really is. It often dictates the initial treatment strategy. But beyond that, we have several main categories of therapy.
Okay.
Radiotherapy still plays an important role. It's excellent for localized bone pain that isn't controlled by painkillers, for treating or preventing pathological fractures, and it's an emergency treatment for spinal cord compression.
Supportive, but important.
Very. Then you have chemotherapy. Traditional agents like melphalan, cyclophosphamide, steroids like dexamethasone, doxorubicin are still used, often in combination. But the biggest advances have come from novel agents.
Ah, yes, the newer drugs.
Exactly. These have really transformed outcomes. We grouped them into classes. There are immunomodulatory drugs, or IMIDs. Thalidomide was the first. Now we mainly use lenalidomide and pomalidomide.
Okay,
And then proteasome inhibitors, bortezomib, carfilzomib, ixazomib. These target pathways the myeloma cells rely on to survive.
Right.
More recently, we have monoclonal antibodies. Daratumumab and isatuximab target a protein called CD38 on myeloma cells, while olutuzumab targets SLAMF7. These harness the immune system or directly kill the cells.
The antibody's very targeted.
Very. And there are others like histone deacetylase inhibitors, like panobinostat, used in certain situations. The standard approach now, especially for transplant-eligible patients, is often induction therapy, using a combination of these novel agents, followed by HSCT, and then often maintenance therapy, usually with lenalidomide. For older or less fit patients, continuous therapy with combinations of these agents is used.
It really sounds like a tailored approach using multiple drug types.
It absolutely is. Combination therapy is key, and treatment is often continued long-term to keep the myeloma under control.
So with these improved treatments, what does the prognosis look like now? And what about long-term follow-up for myeloma and those related conditions?
the outlook has definitely improved significantly. Thanks to these novel agents and stem cell transplants, median survival times have easily doubled or tripled over the last couple of decades. It's still generally considered incurable, but many patients can live with myeloma as a chronic condition for many years, often with good quality of life.
That's encouraging progress.
It really is. Now, for those related conditions, solitary bone plasmacytomas, as we mentioned, have a high risk of eventually progressing to full-blown myeloma, maybe 50–70% over time. So they need very close follow-up, often with regular imaging and blood tests, or sometimes they are treated up front with radiation or even systemic therapy, similar to myeloma.
Okay.
And for MGUS, that risk remains about 1% per year. So lifelong annual monitoring is generally recommended, especially for those with higher risk features like an abnormal free light chain ratio, just to catch any potential progression to myeloma early.
Vigilance seems key across the board then.
Absolutely. Regular monitoring of blood counts, kidney function, calcium, and importantly, the M protein levels and free light chains is standard practice for managing all these conditions long term.
Well, this has been an incredibly thorough journey through multiple myeloma. We've covered the definition, the how and why of the pathophysiology, the clinical signs, diagnosis, the crucial differentials, and the evolving landscape of management and prognosis. Really vital information for anyone in medicine.
I think what's truly fascinating, and maybe a final thought for our listeners, is seeing how our understanding of the interaction between the myeloma cell and its neighborhood, the bone marrow microenvironment, keeps evolving. And it's that understanding that's driving the development of these smarter, more targeted therapies. It really makes you wonder, doesn't it? How will personalized medicine, looking at each patient's specific myeloma genetics, continue to shape treatment? How will we get even better at predicting who needs which therapy, offering even more hope in the years to come?
That's a really powerful question to end on. The future definitely looks brighter, but the complexity remains. Thank you so much for walking us through that. And thank you, our listeners, for joining this deep dive. Keep learning, keep questioning. We'll catch you next time on the deep dive.